Good morning, Chicago. I'm Dr. Allison Hourdy, Commissioner at the Chicago Department of Public Health. Today is Tuesday, September 28th, 2021. And as always, we are here to take your COVID questions. Sorry we started just a couple of minutes late. I was running between places, and always at all times these days I feel like I'm just running a little behind. But the good news is that everything in the COVID response continues to go really very well, and we want to answer your questions. You can put them into the box below. You can also use the hashtag AskDrArwady on either Facebook or Twitter. So let's go ahead and dive straight into our dashboard. Chi.gov/COVID- is where you always go to get the up-to-date information about COVID numbers in Chicago. Just as a reminder, you can look at cases, deaths, hospitalizations. On this tab, you can look by zip code here if you want to see what's happening with cases, deaths, hospitalizations. You can look by age, race, ethnicity, everything. Explore here. Testing is where you can see what's happening with testing across the city and percent positivity, et cetera. Vaccines, you can look at things like how quickly are we increasing in different areas, different groups, and then vaccines by zip code. But in the top line, really looking good here. We are averaging 369 daily cases here in Chicago. And yes, that is under our 400 mark. We've already had a few of you writing in from Twitter, and I'll talk about that in just a second, but it is very exciting to be under 15 cases per 100,000 here. Hospitalizations, so you can see this is down 16% from last week. Hospitalizations are looking good and are down. Deaths are down a little bit. Vaccinations remain right around that 3,900, 4,000 mark, up from our low in early July, down a little bit from last week. We're doing a lot of testing here. Look at this, 18,000, almost 600 tests per day. And in that setting, you know, the most we ever did as a city in November here was just over 19,000. So particularly as there's more testing happening in employment settings and school settings, et cetera, we are seeing more testing happening. And in that setting with more testing, we're seeing that positivity continue to drop, 2.6%. So as a reminder, we always look together at cases and positivity. Positivity is impacted by the number of tests performed as well as the cases, but all of the news continues to really be good. So I want to bring up a few slides here just to put that in a little more context and actually answer some of the questions that were already coming in this morning. So first of all, let's start with boosters. Everybody has been asking me their individual booster questions. This morning somebody stopped me on the L to ask if he should get a booster. So I want to just make sure all of you have the understanding of what the guidance is. So over the last week or two, the FDA was weighing in, and then the CDC was weighing in, and there were a lot of different changes. Here is where we have landed. Boosters at this point, first, are only recommended for people who got their first 2 doses with Pfizer. The Pfizer booster is the only one that has had the full evaluation and has that emergency use authorization from the FDA. And so if you received 2 doses of the Pfizer vaccine, you should receive a booster per CDC if you fall in 2 categories. First, if you're over 65 or a long-term care facility resident. That group should receive a Pfizer booster. When should you get that booster? You should get it at least 6 months after the Pfizer primary vaccine series, meaning 6 months after your second dose of Pfizer. If you are over 65 or in a long-term care and you got Pfizer the first time around, when it has been at least 6 months, you should go ahead and get a booster shot. And that's because the benefit-risk balance is really the most favorable for adults over 65, where we have seen more breakthroughs or hospitalizations and deaths. Although they remain very rare among people who have been vaccinated, it really tends to be people in this age category. So please get a booster if you are in that group. Also, people 50 to 64 with underlying medical conditions should receive a booster. So this morning, when the person on the L asked me, my first question was, which vaccine did you get first? And he said Pfizer. And then I said, how old are you? And he was over 50. And so I asked about his underlying medical conditions. And if you have underlying medical conditions, and there's a whole range, if you want to see what the details are, I can take questions. But really, you should receive it. And again, this just has to do with as people are getting older, even if they've been vaccinated, with how much more contagious the Delta variant is, there's more risk for potential severe outcome. So those are the two groups that we are recommending should get a booster. They also added in two groups as may receive a booster. And this is because people in these groups are going to have different levels of risk, different levels of possible exposure to COVID, perhaps a different history of having side effects when they got their first doses, for example. And so CDC said two groups may receive a booster. Younger people, people who are 18 to 49 with underlying medical conditions, and then people of all ages, 18 to 64, who are at increased risk for COVID exposure and transmission because of where they work or where they live. So an occupational setting, for example, if I were younger and I were working every day in a COVID ward, I would get a booster. Even though I trust my vaccine, my risk for COVID exposure is much higher. Or institutional settings, if you're working in some of these settings that we know have been higher risk for transmission. If you're working very closely, even though we've had really amazing, really very good vaccine uptake actually here, for example, in our homeless shelters, nevertheless, we know those congregate settings can be higher risk, and you might get one there. So generally, if someone is younger and pretty healthy and not in a setting where they're at increased risk for a lot of COVID exposure, the guidance is may receive a booster. And that's because the vaccines continue to work beautifully. They work beautifully in all groups for hospitalization and death. The most important thing is to get that primary dose. Even for you personally, if you're like, oh, should I get a booster? Should I not get a booster? It's actually more important for you to work to get everybody in your network who is not yet vaccinated with their first and second doses done. That actually will protect you more than you getting a booster. So I'm sure people will have some additional questions, and feel free to put them in. Moderna and J&J boosters, the FDA has said they expect to be evaluating these, and I put the quote, in the coming weeks to swiftly make additional recommendations. I expect we will see some more news about Moderna probably in October. I can't guarantee that, but I know it's coming. J&J, not too much behind that. So at this point, there is not a recommendation that if you got one of those other types that you should go ahead and get a Pfizer booster, and we will have some more information there. And again, the most important thing is did you get that first dose? And I'm very comfortable in the fact that I had my two doses, even though I'm at that 6-month mark. And then finally, for public health purposes, whether that's I need to be vaccinated because I'm a healthcare worker or, for an employment setting, or whether it's related to need for quarantine or travel, any of these things, at this point, you continue to be considered fully vaccinated when you've completed the primary series, meaning if you are 2 weeks post 1 dose of J&J or 2 weeks post 2 doses of either Pfizer or Moderna, you are considered fully vaccinated for public health purposes. So I wanted to just take a minute and lay all that out because we had a lot of questions already coming in, and I'm happy to help address more specifics. Now I'll go a little more quickly and put our numbers in some context. So with our current daily cases of 369, really happy to say we have seen this indicator move from high transmission or high risk back to substantial transmission or substantial risk. We also have our test positivity, our hospital capacity, and our ICU capacity all back down at that lower transmission or lower risk level as well, which I'm really pleased about. So some of you were asking, what does this mean for masks? And what I will say is, first of all, as always, this is the first day we have been back down in this substantial risk category. We always want to see one incubation period. You want to make sure that where you're seeing progress like this, it is not just a blip, that you're holding it, but the news really does continue to look good. Just as a reminder, the CDC recommends that anywhere in the country that is at substantial or high transmission, masks be worn in indoor settings. So per CDC recommendations, masks should stay on really until this indicator, all of our indicators, are at that lower transmission rate. What we did here in Chicago earlier on was we recommended indoor masks for substantial transmission, and we required them when we got to high transmission. Currently, there is a statewide indoor mask mandate. update, which applies in the city of Chicago, regardless of what additional things the city may have in place. So that came after Chicago had made that move. So the point is, right now, the masks stay on, and we will keep you updated as we see how the numbers continue to move here. CDC has the recommendation across the whole country: when we are in substantial or high, masks should stay on indoors. And again, if you have questions about that, put them in. All right, our travel advisory update. No change from last week. California and Puerto Rico remain the only two jurisdictions in the United States that are under that 15 case per day mark. Connecticut is the state that this week has gotten, is under that 15 mark for the first time this week. If Connecticut stays under 15, they would come off next week. But really, although the country is seeing some improvement, we remain in a not great place in terms of how hard COVID continues to hit. And to put a finer point on this, I pulled this just this morning off the New York Times. This is the same data that local governments are looking at and the Centers for Systems Science and Engineering at Johns Hopkins looks at. But this is freely available. And I like this because it gives you a sense of really where we are seeing trouble. If you've been looking at these all along, Chicago has remained in really good shape compared to everywhere around us, which I've been pleased about. Nationally, we've seen a lot of improvement. We're currently across the country averaging 28.7 cases per day. Last week, that was at 35.8, so we're seeing some improvements, but parts of the country are still having a lot of trouble. You see, we are currently at the 13.6, so as has been all along, the risk across the whole country, we remain at less than half of that risk. Alaska, do you see how dark purple Alaska is? That darkest purple, they're averaging more than 250 cases per day per 100,000. I actually have a very good friend who works in northern Alaska, and I was talking to her, and she just said their healthcare system is not able to handle things right now because they have to be flying people often when smaller health settings run out of space. And so Alaska is an example of a setting that really is having a lot of trouble right now. And they're averaging 112.1 per 100,000. So not just, a couple of times that 15 case rate, but more than, what would that be, 6 or 7 times. So that's just some context. Our hospitalization data looks similar. I encourage you to explore. We also were getting some questions about hospitalizations by age group. There were some people who were hypothesizing that as we've come back to school, that hospital admissions for children have really shot up in Chicago. That is not true. We did a press conference last week with representatives from 6 of our children's hospitals here who were highlighting that there are a lot of kids in the hospital right now, but not with COVID. For example, at Lurie Children's, the lead of that hospital said, on the day that we did this press conference, they had 380 something children admitted to the hospital. 4 of them had COVID. So I just wanted to put this in some perspective that over this whole small surge we've had with Delta, on the x-axis here, the bottom is the date. So you can see starting in July when things started to increase. The dark blue is Chicago residents 0 to 17. The red is 18 to 49. The light blue is 50 to 64, and the yellow is 65 plus. And so you can see that it has not been driven by children, and in fact, we've not seen any increase in this with the return to school, which is what we expect, but that has been reassuring to see. I do want to highlight, we update these every week. You can find them online, but we continue to see much higher COVID case rates among unvaccinated Chicagoans. And by that, I mean people who have not gotten any vaccinations compared to people who are fully vaccinated. We had a question in from Juan Jarangia from Twitter, who actually had a question about the footnote here. So thank you for reading the footnotes, Juan, which says that fully vaccinated is defined as completion of the vaccine series at least 14 days before testing positive. And he had asked, does that mean that unvaccinated cases had actually been vaccinated? No, it does not mean that. People who are unvaccinated here have not completed, have not been vaccinated. Like it's as basic as that. And we do compare those rates. And so by far, the biggest risk factor remains not being vaccinated. True in Chicago, true across the US. And if we look at the difference for hospitalization rates, you see that same separation where much higher rates, in this case, some of the decline as our outbreak is coming under better control at the community level, right? You see some of those drops, but the difference still is huge. And then similarly, death rates, where unvaccinated, so much more likely, like 15 times more likely to die if they are infected with COVID. And that's right here in Chicago, and that's recent data, and it's been borne out all over the country. So I know not everybody is moved by data in the way that I am, but these are just really compelling graphs. And you've heard us talk about that, particularly for kind of middle-aged people who are Black and Latinx. In some of those groups, you're 50 times more likely to die if you are infected with COVID and you are unvaccinated versus fully vaccinated. And there's very little that we have in medicine that can protect you against death, at a rate of 50 times. So. Pleased to see people continue to get vaccinated. We had a really good weekend last weekend at a lot of our events, but we have a long way to go. All right, some quick congratulations. We have 2 zip codes, 60624, Austin, East Garfield Park, Humboldt Park, as well as 60636, which is Ashbourne, Auburn Gresham, Chicago Lawn. These had the biggest increase in first dose vaccine coverage for those over 12, those who are eligible since last week. Really good to see, because those are 2 of the zips that we're making the most progress on. With our Protect Chicago 77, of course, our goal is to get the whole city, up to at least 77% having gotten that first dose. And these are some of the zips that I'm the most excited to see progress in. So cheers to them. I also, just as a reminder, all zip codes have reached that 50% mark, where the majority of Chicagoans over the age of 12 in every zip code have had a first dose of COVID vaccine. We've got 39 zip codes that now have at least 70% of eligible Chicagoans have gotten that first dose. The dark blue represents those zip codes. You can see new this week was 60629, Beverly, Morgan Park, and Mount Greenwood. So congrats to them. And we're still working on the ones that are not shaded in. And then we had 2 new zip codes this week reach that 80% mark. So congrats to 60625, Albany Park, Irving Park, Lincoln Square, North Center, North Park, and 60629. And boy, that 60629 is one of those zip codes that is burned into my brain forever, because it was hit so hard by COVID early on. So I love seeing that zip code be one of the ones leading the city in terms of vaccination coverage. All right, so that was a lot of talking, but I wanted to hit some of the questions you had right off the bat, and now we will move into your questions. All right. So a few questions here. I see @BizzleScott2 on Twitter. I see Stephen Russian on Facebook asking, now that the city has fallen below that 400 cases per day rolling average threshold, when could we expect the mandate to be lifted? Have we been in contact with IDPH about coordinating state and local mandates at the same time? And then I'll actually just also add on here, Karen. Actually, I'll take your question in a second. Let me hit those 2 first. So definitely we have been in conversation with the state. So like I said already, at a minimum, we want to see two weeks of good improvement. CDC says keep the mask on inside when you are at substantial or high risk. And the state requirement remains in place across the whole state. I have been talking to IDPH about the idea of could you use a regional approach when it comes time to be thinking about masks, for example. But the other concern here is that as we are heading into colder weather, and frankly, moving indoors is likely to, I would be surprised if we did not continue to see some increase in COVID cases. There's some worry about saying we're going to take the mask off, put the mask back on, take the mask off, put the mask back on. So what I would say today, like I already said, is that this is good news that we've fallen behind it. We want to see that sustained. Yes, of course, we'll be coordinating with the state and working on this. The recommendation from CDC is that while we are at that substantial or high risk level, the masks stay on, and we'll give some more guidance as we see if this is sustained improvement. But it is really good to see, and we will be talking about what comes next here. particularly in settings where everybody in them is fully vaccinated. I think that's where there's the most potential to think about. Okay, now I'll take Karen. Karen Skotowski-Felber on Facebook is asking, why aren't you using positivity rates to determine opening the city rather than the number of cases? So like I said right at the outset, you have to look at case rates and positivity together. And let me sort of explain how that works. So across the whole country, the CDC, for example, looks at both case rates and positivity. Positivity mostly tells you about whether you are testing enough in a setting. So automatically, any setting across the US per CDC, if you're over a 10% positivity, for example, you are in high risk no matter how many cases you're detecting. If, on the other hand, you're testing very well here, and like here, we've kept our positivity below 5%, you look at the case rates. And I encourage you to check the CDC website if you're interested in learning more about this. Very strongly, it is whichever of these puts you at higher risk, you use that higher risk category. Because, let's play this out a little bit. Let's say I had a imaginary society with 100 people in it, okay? And nobody wanted to test for COVID. Let's say one person tested for COVID, but there was actually a lot of COVID in that community. Our positivity rate could be 100%, but the case rate would only be 1 per 100. You have to look at both of those together. And if you have a positivity, that's 10%, you just know there's not enough testing there, and automatically you go into high range. As long as you know there's enough testing, which basically means staying under 5%, you are then able to use some of those case numbers. So we think about both of them together because they go together. And also, we think about the reason I show you those 4 metrics all together is that they're all linked to each other, and they all have to do with citywide decisions. When we are seeing a high number of cases, we know, especially when testing is good, we know that the risk is just greater when you are out and about around Chicago. The 2 bottom numbers, which are how are we doing with hospital capacity, which is good right now, are the things that if we were to see major problems with that, we would potentially need to take more aggressive action. But the bottom line, the news is good right now, and I'm really happy to say it's the first day, since August, I believe, that we've been under that 400 mark. So good to see that. All right. All right, Emma Woodhouse on Twitter has an interesting question. She says, why is the city's definition of unvaccinated misleading? It includes 0 dose, 1 of 2 dose, and full dose of less than 14 days. So we actually do have data, and we share it with some more of that breakdown, but the comparison, when you are considered protected, okay, in terms of everything, in terms of when I am confident that you have good protection from COVID, always, all along, has been 2 weeks post your final dose of vaccine. So 2 weeks post your second dose of Pfizer or your second dose of Moderna, as well as 2 weeks post your J&J. And so the difference is fully vaccinated versus not fully vaccinated. We have in the past, we've shown sort of unvaccinated is here, partially vaccinated, we see some protection there, but especially with Delta, it's actually not enough to be partially vaccinated. So if somebody has only had 1 dose, but it was J&J and they're 2 weeks post that dose, they are 100% counted in the fully vaccinated category. So I hope that helps clear that up. Okay, so a number of you are writing in with questions about, Margot Fisher, I don't understand your question. Margot Fisher on Facebook says, why do I keep saying the numbers are going down when they are clearly going up? Can you please clarify? Because the numbers are going down. So maybe you're talking about the state. Southern Illinois is not doing as well, which is part of why I showed you that map. So when I'm talking about Chicago specifically. The state remains at a higher rate overall. And obviously, when any part of the state is having trouble, there is some concern for us. But if you want to clarify that anymore, I'm happy to address it. Okay, there's a couple of questions here about boosters and protection levels. So let me take a couple of these. Jean at JB Tross on Twitter, for example, says, how long does the booster shot take to bring decreasing protection levels back up? Is it 2 weeks? And we've got a few variations on that. Okay, let me explain a little bit more kind of about the background of boosters, all right? So first of all, I know I said it, but you got to say it every time. The most important thing is to get that primary, or if you're getting a 2-dose, get those first doses. And if everybody in your network is fully vaccinated, your risk is much lower overall. The booster recommendation came from the fact that, especially in people who are older, over 65, we are seeing some more breakthrough cases. And we are seeing, it is unusual to see breakthrough hospitalizations or deaths, but where we have seen them, they tend to be in older people. Last I looked at it, I think our median age for hospitalizations of breakthroughs was close to 70, and our breakthrough deaths was close to 80. And this is not really unexpected, given that we know generally as people age, your immune system changes. So, for example, there are a number of vaccines, setting aside COVID, that actually, once you reach the age of 65, we recommend getting a booster of or a vaccine of. So when I was in clinic last night seeing patients, if I see someone over a particular age, there's a special pneumonia vaccine, for example, that is recommended for people who are older or who have underlying conditions. The shingles vaccine is recommended over a particular age. And even the flu vaccine, depending a little bit on the year and what's going on, there is a higher dose flu vaccine that is made specifically for people who are older, recognizing that often they just need a little more boost to immune systems to have the level of protection that younger people will have. But the bottom line is, for all ages, the vaccines continue to be really, really good. This question of sort of what happens when I get a booster and how do I follow antibody levels. So antibody levels are not by themselves the measure of protection. And I know that's confusing for people. And I had some questions in here about why can't I just get an antibody test every few weeks and see if I remain protected? There is no antibody test that will tell you if you are protected. There is no antibody test that will tell you if you are protected at an individual level. I have never had an antibody test, ever. I don't intend to get one. At a population level, we can look at this, and over time, one of the things the scientists are working on really hard is getting an equivalent test that we would have that for. So for measles, we have a titer, it's called, where I can get my blood drawn, and we can look at the level of protection, kind of like the antibody level, and I can be pretty confident that I have a good level of protection back from when I was a baby and I got my measles vaccines. We don't have that yet for COVID. And this is because it's not as simple as just tracking the antibodies. There are different types of antibodies, and then the antibodies are like what your system makes right away when it has just learned that lesson. So whether you've been vaccinated, your system is starting to make those antibodies, or if you're recovering from infection. There's some difference in the types of antibodies of those, but the bottom line is right away, after you are recovering from COVID or after you have had vaccine is when those antibody levels are highest, because you've just churned out to sort of either fight off the infection, hopefully, or your immune system has learned that lesson for how to protect you without actually making you sick. So either way, people are learning that immune lesson, and right away that level will be highest. Always, for all infections, not just COVID, those antibody levels that we check in your blood drop over time. It is normal that they do that, because it's not just COVID. Every time you get exposed to a cold, you get exposed to any sort of virus infection, your body makes antibodies again against those. And so it's not only about antibodies. There's more to the immune system than antibody levels. There's B cells and T cells. There's these cells that can kind of live in your bone marrow, and they're not churning out antibodies all the time. But if you are exposed again to something that they have seen before, they will churn out antibodies again. So if you are vaccinated and you have these T cells, for example, and these B cells, this is a lot, so I'm not going to go into more detail, but let's just say these cells that are not the ones already in your blood ready to fight immediately, they're the ones that are sitting in your bone marrow waiting to say, uh-oh, I see COVID coming in, let me start churning out antibodies again. And so you can't just do a one-time test or even a repeated test and say this level is good enough. It's why the epidemiology here is so important. So it's why we've been putting so much resources into things like comparing the levels between people who are fully vaccinated and unvaccinated, why people in the trials have continued to have their levels drawn. And we are working on titers. But there, measles we have a titer for. Mumps we've never successfully developed a titer for. It's just different depending on the different type of virus. But it would be great to have a blood test and know whether or not you have to be concerned or whether your protection level is high. But we do not have that, so I don't want people thinking they should get a test and sort of know that they're protected. So in terms of how long would it bring those protection levels back up? Is it 2 weeks? Yeah. I think generally right after you get that booster dose, you basically have, in a safe way, get taught your immune system again how to respond, how to build up more of those cells and more of those antibodies. And I would think that you would really, over those first couple of weeks, be seeing that increased risk of increased protection level. But it's not so much. Yeah, I think we'll leave it at that. And if you have additional questions, feel free to chime in. But yes, when you get the booster shot, I would say think of it as giving another lesson that probably your best protection is those 2 weeks or immediately right after, but it's not just about those 2 weeks. It's about, again, building up more of that memory, building up the ability for your body in a long-term way if you see COVID to fight it off. And maybe I will just very quickly, because I see there's some more questions about Delta and whatnot with this. One of the things that's been interesting with Delta is it's so much more contagious. And we think, the different antibodies get made in different ways. There are some that tend to live in your nose. There are some that tend to work a little more in your lungs. The vaccine is particularly good with sort of protecting your lungs, a little more than it is probably with protecting your nose. I'm really oversimplifying this, but to give you the idea. And so there's this sense that people, particularly with Delta, that is so contagious and very quickly doesn't take a lot of viral exposure to get COVID in the nose. It's why we're maybe seeing more breakthrough tests, because we're testing and we're seeing it. But your cells from being vaccinated are able to fight that off really well in the lungs. And we worry, testing in your nose is not what makes you sick. It's what usually when people get seriously sick, it's when it has a chance to settle in the lungs and give people pneumonia and respiratory failure and all of that. And the vaccine is able to, to ramp up to protect sort of the lungs very well, those more severe outcomes. So we think that's a little bit why we've been seeing more of the breakthrough infections and still really good protection for hospitalization and death. So, okay, that was a lot of, I wasn't necessarily expecting to go down that science hole a little bit. So let's try to get some more in quickly here. Is the, Ayani Good from Facebook, is the third shot, she's basically asking, is the booster going to be a different dosage, or is the third shot the same? For Pfizer, the third shot is the same. So if you got your first 2 doses of Pfizer and you're 6 months later, your booster is the same. It's teaching you the exact same lesson. That's some of what they're studying with Moderna and J&J, but Pfizer is the exact same. Also questions here, a number of people about flu shots and COVID boosters at the same time. Jean Brooks on Facebook says, yeah, I got my COVID booster and flu shot yesterday. Good job, Jean. And yes, you are, and multiple people are asking, do I need to space this out? You do not. You are welcome to get your COVID booster and your flu shot in the exact same appointment. You don't have to. If you're worried about side effects and you want to space them, feel free. But you can get a booster of COVID. You could also get your first dose of a COVID vaccine if you had not done that yet, or your second dose, any of them. And that's true for any of the vaccines now and the COVID vaccine. So if your child needs to come up to date with their vaccinations, if they missed them during COVID and it's an adolescent, they can get that COVID vaccine at the same time as the other shots. And we are really, CDPH, we always do a lot of flu vaccination clinics and outreach. There's some questions about will we be doing large sites as part of our flu family clinics. We will be working again with city colleges, not opening them for extensive periods of time, but having days, and there will be flu and COVID vaccines available. But you can get a COVID, people are asking, how do I get it? You can go to a pharmacy, you can go to your doctor, you can go to any of the sites. If you go to chi.gov/COVIDvax, they are all offering boosters. And if you are over the age of 65 or 50 to 64 with an underlying condition, you should do this. If you are in those younger groups and you're at high risk and worried because of your work exposure, or high risk and worried because you have a serious condition, you are also eligible. You may get one. And Don Wolf is asking that on Twitter. Are restaurant and bar workers eligible to get a COVID booster, and should they get one? They are eligible, assuming that they are in settings where they are working with the public. This is going to be an individual level decision. The most important thing is that restaurant and bar workers get that primary vaccination series. Certainly if they're older, they should get one. If they're younger, I think it depends on what they feel like their risk level is and whether it's something that they want to get. But yes, they're definitely eligible and welcome to get one. They remain considered fully vaccinated for public health purposes as long as they've gotten one J&J or two, either Moderna or Pfizer. Brandon Kristen Munden, PE, these are long, at Brandon724333129 from Twitter says, are the viruses that make it through a vaccinated population more virulent than those that went in? Okay, I think, Brandon, you mean, are these breakthroughs sort of more virulent? Are they more dangerous? And the Delta variant, which is the variant at this point, like still more than 99% of our cases here in Chicago, in Illinois, across the US, remain the Delta variant. It's more contagious has been the main thing. It's not that it's necessarily making people significantly sicker, but it takes a lot less exposure. And that's the other reason why CDC has been recommending the masking indoors, and that we've been seeing more breakthrough infections, including among those who have been vaccinated. And so some of you are saying, we shouldn't need to have the masks if we're fully vaccinated. The vaccine has never been 100% protective. I wish it were. There's no disease for which a vaccine is 100% protective. And particularly when there's a lot of COVID in the community, which there has been. It's our first day back under 400 cases diagnosed every day in the city of Chicago, not even including those who might not have been diagnosed. The risk is just higher when you're out and about. And a lot of what I talk to a lot of people who get breakthrough infections and they feel like, oh, it was my fault. No, it wasn't your fault. As long as you're fully vaccinated, you're wearing your mask when you're indoors. But it is true that you can get COVID and you could potentially spread it, although the risk is lower. And that's why those two recommendations fall separately. And so Kim McDonald on Facebook is saying, why are vaccinated children told they don't have to quarantine if they're a close contact at school? Couldn't they carry and spread the virus? So this is all over the country, not just here. Everybody, this very strong recommendation from CDC and elsewhere is that children don't have to quarantine if they are vaccinated, because we have so many other mitigation measures in place at schools, right? The masking, the distancing, the pods, all these different things were shown to be effective even before a vaccine was available. Vaccine adds further on to that. And we have data where when you quarantine kids, the great majority of them don't end up developing COVID. And if they're vaccinated, almost none of them do. So that's why. And I hope that you're always looking at numbers and statistics when you're making those decisions. But that is the recommendation of not just the Chicago Department of Public Health, but really all public health agencies that I'm aware of across the US. All right. So a couple of questions here about Chicago Public Schools and cases that are self-reported. So we've got Miriam on Twitter saying, how are Chicago Public Schools that are self-reported, maybe not lab test or report to start with, included in the COVID dashboard? Are these self-reported tests lab replicated? Stephanie Whitfield Smith, how are SARS-CoV-2 home tests reported to the health department? Eric at Toba from Twitter, are all tests in schools, workplaces, test sites, doctor's office, et cetera, reported to CDPH? Is it possible to report results of a home rapid COVID test to CDPH? Okay, good. So let's sort of take testing and home tests in schools and talk a little bit about all of this. So there are tests that are, so on, who was it? Eric's question first. Are all schools in, are all tests in schools, workplaces, doctor's office reported? By law, yes. If you are doing a formal testing program, if you are getting a test through a lab, if you are getting a test at the doctor's office, if you are getting a test at a walk-up COVID testing site, these places have the certifications to basically say the way you are being tested is appropriate and I stand by the results of this test. Those tests by law all have to be reported to public health, and those are all reflected in our case numbers. Self-tests, so people asking about these at-home tests where you can take a test yourself and you can do like a pregnancy test at home and get a result. I love these tests because I think from a public health infection control standpoint, they're extremely useful. If you are going to go see somebody and you are worried because there's someone who's super high risk, the ability to do a quick rapid COVID test at home I think is huge. But in terms of those being formal tests that show up in reporting, they typically do not, and I'll get back to typically, because there are some of these that come with actually applications. And if you buy one of these, I encourage you to actually use the application that comes with the test. There are some that you can actually do a video visit where someone watches you actually take the test and can therefore certify that yes, this is you taking the test, and yes, you have actually swabbed your nose and done it appropriately, and you do it, and they can certify, yes, this is a test that I, as a healthcare professional, for example, certify has been done in the appropriate way, and I have seen the result. There are also, there's been a lot of work with these through the American Public Health Laboratory System, electronic health records, et cetera, to think about capturing these tests. But the problem is that if somebody calls and says, I have a positive test, if they call their doctor, if they call the health department, there's two things that we're worried about there. Number one is we always are going to treat that test like a positive test, okay, in terms of like public health control. We're going to make sure that person understands what they need to do related to their exposures, what they need to do related to isolation. Their doctor is going to make sure they are doing okay, right? Like if they're not doing well and they could need a higher level of care, they could need treatments, right? So there's the like taking care of the individual person and making sure there's guidance. And then there's the question of what do we do with that test result? And there are laws about, a doctor sort of can't, and a lab can't officially say, we know this, we confirm this person had COVID unless they have a test result. So in the same way, if you take a pregnancy test at home and you come in and you say, I had a positive pregnancy test, it's not that we don't believe that pregnancy test and act on it, but we always recheck it because there could be situations where people have a reason to want to say that they have COVID and they don't, or there is a reason why people want to say they've tested for COVID and they haven't, et cetera, et cetera. And so it's not that we don't believe people or act on it, but in terms of sort of reporting official results, they're ones that are officially reported through a doctor's office, a laboratory test, et cetera. And so when it comes to CPS, when people are calling with a self-report test, yes, we treat it, as a positive test. But in terms of actually numbers and knowing it's true and doing the follow-up, they are able to get the more formal tests at school, for example, that then those are reported. Anything in a formal testing program is reported. So I hope that helps clarify. Please, if you're using an at-home test, take a look at the application because it lets you report report. It helps keep track of it for you. And over time, as I said, nationally, we've been very interested in ways sort of to collect this as a separate data stream. But it's a little different than a lab-confirmed test. So I hope that clarifies it. And if you've got more questions, happy to put it in. So we are just about coming up on time. Ricardo Islas is asking, when are we going to talk about natural immunity? So when I talk about people recovering from COVID, that's what I'm talking about, natural immunity. Natural immunity is not the same as immunity from vaccination. We know that people have some level of protection after they have had COVID infection, natural, quote unquote, natural immunity. It's different than the immunity, even in terms of how your immune system is responding, we believe, from when you are vaccinated. And you've heard me say a lot on here, the people with the best protection rates, at least some of the best, most compelling basic science data I've seen, is when someone has both recovered from COVID and had a vaccine. That combination seems to give, makes those B cells and T cells, and sort of where there's been more studies actually looking at bone marrow, that seems to be the best combination. But whenever we're talking about people who have recovered, for example, that is that natural immunity piece. And unfortunately, there are still we estimate more than 760,000 Chicagoans who do not have evidence of, quote, any natural immunity. And we know that because there are studies that happen where people are getting blood drawn for other reasons without identifying it. There is work that happens to look and see, do these people have antibody levels for COVID? Remember, at an individual level, I can't tell you, but at a population level, we can see how many of these people have some evidence of protection against COVID. And there are actually different tests that you can do to see, is this probably from recovery after an infection versus after a vaccination. But unfortunately, there's still about 760,000 Chicagoans who have no sign of immunity, we estimate, either from natural recovery or from vaccination. So there's still a whole lot of people here. Those folks are going to, along the way here, they're going to see COVID one way or another. They're going to learn that lesson. I hope most of those people, many of those are children who are not yet eligible, but hope is that many of those people will choose to learn the lesson, that safer way through vaccination. But yeah, we definitely track this. Okay, so if you've got more questions on any of that, put them in. I probably will be back on Thursday. It actually is our budget hearing day for City Council. So if you don't know, all of the city departments during the budget process go in front of City Council, the aldermen, and answer questions about their budget plans, answer questions about the work that they've done. And so depending a little bit on the timing of that, I may or may not be able to be on, but hopefully I will. And if I'm not able to be on Thursday, we'll come back and get some more of this soon. Thank you for your thoughtful questions. If we didn't get to you today, we'll get to you next time. In the meantime, please be well. Work on getting anybody vaccinated who isn't, and we will go from there. Thank you.